just made you co-host so you can share your screen whenever you're ready.
Okay. We were talking with Dr. Hernandez about the the importance of the selective laser trabeculoplasty for the management of glaucoma, and that it's a resource that we have in the hospital but isn't so much used. So first of all, it is a minimal invasive laser treatment modality for the management of an open angle glaucoma. It works by lowering the IOP by enhancing outflow of the aqueous humor through the trabecular meshwork. It works in a 532 nanometers frequency double switch, and we use it with a neuridium, yttrium, and argon laser. The target are the pigmented cells of the trabecular meshwork. The target of the laser is the melanin-containing cells in the trabecular meshwork, stimulating the cellular activity and enhancing the aqueous outflow without causing significant thermal damage to the surrounding tissue. And now it is also available, the MLT, that it causes less thermal damage on the tissue of the angle. So what we have to do the SLT, we already know that we have to put the patient under a slit lamp. We use a contact lens on the cornea to focus the laser into the trabecular meshwork. We use the topical anesthesia. We use it before put the lens, and then we can start the laser, and it lasts from 10 to 15 minutes per eye, and it is well tolerated by most of the patients. But I had some of them that we have to stop the treatment for a while and then we can continue, but most of the time it is well tolerated. So which are the indications, or that's very important that we can do it with every patient? We can use it to primary and open angle glaucoma, secondary glaucomas with pseudofoliation and pigmentary glaucoma. And when we have to adjust to medication when they have an inadequate control or topical medications, contraindications to specific glaucoma medications. And we can also have as the first line in some populations as the ones that has patient seeking a non-pharmacologic approach, or the ones that have poor medication adherence. Also, we have to take it in account when we have a pregnant woman, or because it is a kind of the first line of approach. The IOP lowering effect of SLT is seen in many patients with IOP reduction, often reaching 5 to 10 millimeters of mercury. The peak of IOP reduction is usually seen 4 through 6 weeks post-procedure, through the full effect may take up to 3 months. It has a maintained efficiency up to 3 through 5 years in some studies after we can repeat. And so it is very important that we can consider it to repeat the treatment when the efficiency lowers. Which are the advantages of SLT over traditional glaucoma surgeries? That it's minimally invasive, we can repeatability, and the preservation of the anatomy of the eye. So minimally invasive does not involve cutting or sutures with a quicker recovery time, and repeatability can be safe repeated in case where the initial IOP reduced in the begins to wane. So
Miriam, do you mind if I add something to that list?
Yeah, Yeah, sure.
I would add, one of the advantages is that we don't have to depend on the patient putting drops. So, and that I think it's our primary goal in San Marcos, because they really can't get the drops sometimes. They can't pay for the medications. So if we do the treatment, we're pretty sure we're bringing the pressure down somewhat. And if we don't follow up with them, they probably get lost, but we know we did something, and we don't have to depend on them putting drops. So I think that is important.
Yeah, and in most of the times it will be cheaper to do one SLT than buying the drops for the entire life. And that's very important for the adherence of the how do you say cumplimiento del
Compliance.
the compliance of the drops. So it have the common side effects it can have is transient meal discomfort or a foreign body sensation post procedure, conjunctival hyperemia, and may occur, but generally it resolves with hours or days. The rare complications is transient increase of the IOP. It will be most common in the 24 to 48 hours post-treatment, can be corneal edema or damage, and peripheral anterior synetia. So the SLT is a safe and effective treatment for reducing IOP in patients with an open-angle glaucoma. Its minimally invasive nature combined with its ability to be repeated and its relatively low risk of complications. It is an important tool in glaucoma management, and as more evidence continues to emerge, SLT is increasingly considered as the first line of therapy.
Andy,
sorry, Miriam. Andy, do you want to add something?
Oh, I just have a quick question on the side effects. I last or 2 months ago, I'd never seen this before, heard it described of a completely normal SLT that I performed in an open angle glaucoma patient. They came back a few days later with 8-ball hyphema. And I'm just wondering if is that described, or is that just super rare, or is that?
Yeah. I have one patient with hyphema too, but was a neovascular glaucoma that was beginning. So it may be there was a vessel of the neovascular vessel on the ankle, and that was the reason.
Mm-hmm. Okay.
Was it pseudoexfoliation?
No, it was not. It was just opening, kind of a generic opening of glaucoma. Didn't see nothing happened during the case. It just occurred later. I just wondering if that's like are some vessels being stimulated, or if that, yeah, I don't have an answer to why it happened, but I'm just wondering if that's something that's anyone has seen before. But
I've never
Very
seen it.
rare.
Yeah, very rare.
yeah.
Are you going to mention the LIGHT study? Because that is a prospective randomized trial that's pretty much shown that SLT is superior as a first-line therapy compared to drops.
Yeah, I was reading about that study yesterday, and it also mentioned something. I know it was a glauco. I don't remember the name. That was talking about that transscleral SLT.
Yeah, the direct SLT that just came out by Alcon. I mean, that would potentially have great use at a place like Hospital della Famiglia. I mean, you can do those things in both eyes in, less than 2 minutes. Put a lid speculum in. I mean, you could have, any technician do the procedure. You don't have to worry about a gonio lens. The only issue here, I think, in the United States is there's a click fee that Alcon collects every time you do it. And I wonder if they'd be willing to donate one and forego the click fee, given, our unique kind of clinical environment. But that would be huge, I think, in a place like, Hospital della Famiglia. I mean, what do you guys think about that?
I think it would be a much faster procedure than a normal SLT. Like you said, you don't need a lens. But I don't know, for some reason the culture here, people don't like to have laser in their eyes for some reason. They'd rather put drops in. I don't know.
Do you find that's true also in your private practice as well?
Yeah.
Interesting.
Yeah. I tend to offer SLT and I tend to offer medication, and they just go for medication.
Yeah, so I guess the question is, what's the limiting factor in not doing more SLT? Is it patient presentation, they're presenting late, or their pressure's too high, they're just not good candidates, or they don't want it? Or is it time and availability of the ophthalmologist to do it? In that case, the DSLT would definitely make sense.
I think that a factor that can affect is that many of the patients have so much advanced glaucoma, so it isn't available to do an SLT because there are a close angle glaucomas with a phacomorphic glaucomas or something like that, or they had the pressure very high. So if you don't you do an SLT, it will be no enough. It could be a factor that makes not use it so much, but it still is a very useful technique that can be helpful in some patients that are so advanced in the glaucoma. We were talking that SLT is safe and effective treatment for reducing the IOP in patients with open angle glaucoma. It's minimally invasive nature, combined with its ability to be repeat and its relatively low risk of complications. It's an important tool in glaucoma, and there are more evidence that it's in. We already said that it is consider it at the first line. So either as a monotherapy or an adjunct to a medical treatment. So it was all I have for you, and thank you for your attention. And I don't know if you have any comments or questions.
Did you find any studies?
I have some here.
What is
Just one comment. There's been some controversy in the US as to whether to use a non-steroidal drop after the procedure. And generally, it's very well tolerated. So I think there's no reason to use it for discomfort. There's been some controversy whether it makes the procedure more or less effective. I think most people, including me, have gone away from using anything post-operative.
Yeah, the SALT study, SLALT, steroids after laser trabeculoplasty, pretty much showed it wasn't a great study, but it showed that if you use steroids, it didn't really blunt the response. But I typically don't. I tell people ahead of time they'll be photophobic the next day. If they're really bad, then we'll call in like a non-steroidal or mild steroid. But I typically don't as well. Don't do that routinely.
And what about 180 over 360?
I do 360.
I always treat
Every-
360.
Yeah, unless there's
too.
like really, really dense pigment, like a pigmentary glaucoma, then I might do
Yeah.
180.
I agree. I do.
Yeah.
180 if there's a lot of pigment. If not, then 360 all the way.
What is the cost? What do we charge patients there for an SLT? Just curious.
I don't know.
Not sure.
Andy, do you know? Or
Yeah, I don't know the answer to that.
maybe this is
We're
Mariana?
checking with Claudia right now. What is it?
Oh, okay.
500 quetzales.
500 quetzales for SLT per eye.
Per eye.
500 quetzales per eye.
And how does that compare to the cost of a bottle of latanoprost?
So latanoprost can be anywhere from 200 to 500.
Okay, so pretty good if you can use SLT as an alternative to the
Yeah.
latanoprost. It's definitely very cost effective.
How long have you had that report that showed that it can last up to 6 to 7 years if you repeat it after the first and second year? What do you guys think about that? Do you repeat SLT and have you seen in your patients that it lasts more than 5 years?
I've had some people go 10 years with
Yeah.
2-3 treatments. It doesn't work as well
Right.
each time you repeat it, but
Right.
for those people that really don't want to take drops, don't want to have an eye dose. I mean, it's worked great in some people, and then some people just kind of poops out after the second treatment.
So you would say that if you had a good response,
First time.
try it again. I mean, it makes sense.
Right.
Yeah.
Right.
And didn't we have a discussion here about 6 or 8 months ago? I think it was here where we talked about increasing the repeat rate and increasing also the number of spots put in per treatment.
I think there's some studies showing if you use maximal energy, like go beyond the usual endpoint, that you get less need for a repeat treatment and less failures. That I think that's been published.
But maybe higher risk of post-procedure IOP spike.
Yeah.
Is it
Yeah.
for that?
Yeah. Maybe.
And inflammation and uveitis could be an issue.
Yeah.
So are you all treating, Miriam, do you treat like 90 spots or do you try to go more like 110 or 120 spots?
I use 100 spots most of the time. As with MLT, 120 spots.
Is MLT big there? Because I think it kind of went through a phase here in the US, and we didn't, with MLT, you can't even see the endpoint. And my impression was it didn't work quite as well as SLT. I don't know, I didn't really have a lot of experience with it though.
Me neither. I just
know the experience.
I've only worked with SLT.
I have done some, but I haven't seen the patients again yet. I did it in the but I was researching about it and said that the number of spots was 120.
So I was speaking with Mark Latina the other day. He's the guy that invented SLT, and he really is really down on this direct SLT. He thinks it's garbage and it won't work that well. So he's actually coming out. I don't know if I'm supposed to share this, but I'll tell you guys anyway. He's coming out with a special lens that will let you do transscleral direct SLT with a regular SLT.
What?
You don't have to spend the 80 grand and pay Alcon the $60 click fee. You can do it by yourself. That's what I heard. And it's supposed to come out like at the end of the year.
But that's interesting. He's saying it doesn't work, yet he's creating a way to do it.
He's saying it's just kind of garbage, the fact that you have this whole new device when you can just use
Oh,
regular.
I see. Yeah.
Well, we'll see. I mean, it seems like, you know, they've talked about using ultrasound. I mean, anything you do, you know, to the eye, if you do it long enough and hard enough, you know, it'll lower the pressure,
Yeah.
you know.
True.
So we'll see. So save your money. Don't buy your drug. Have you used it or had any experience with it? You know, Jeff,
I have not. No. Just-
your practice isn't going to buy one.
No, we're not. I think Rob Noacker bought one.
I just emailed Terry Kim to see if they'll give us one. Terry's now the
Oh yeah.
he's the chief medical officer for Alcon now.
Yeah.
So we'll see.
Never hurts to ask.
Never hurts to ask.
Jorge, I'm just curious, did you ever think about maybe just trying a subset of 10 patients that you would call it like light beam therapy or something and not use the word laser, and just to see if that would make any difference psychologically?
I haven't, but I think it's a great idea. I think, you know, change the approach.
Mhm.
I think there's a stigma with the word laser
Mm.
somehow.
I
I
agree.
think it's a marketing problem. Yeah.
I think it is.
Mhm.
We should
I had
yeah.
an attending during fellowship who would tell his patients when he was doing a argon laser or LPI, he'd describe taking all the different colors of the rainbow and picking one color and using it to just gently, you know, massage the eye or something. I don't know what it is. I mean, it was really kind of pushing the limits, but it worked, you know.
Yeah. Or you could just call it SLT and not spell out what it stands for.
Yeah. Yeah.
Yeah, I mean, I tell my,
Try it, Jorge, and report back to us.
Yeah, I'll try it and I'll tell you guys. Let's do a little small trial.
I mean, I tell my patients, like, no one's ever gone blind from an SLT. It's one of the
No.
safest lasers we have. And if another doctor looked, you know, at the patient's eye a week later, they wouldn't be able to tell that anything was done. It doesn't leave a trace. And so I don't say it's
Unless they have
surgery.
an 8-bulb HIFEMA.
That's what happened to me.
Well, that's just
Yeah.
Andy's technique, okay? That's, you
Then you
know,
have to go to
he
San
has
Went
a
away
Francisco.
after a
really
week.
mean SLT.
It was gone after a week.
Yeah.
The other thing I think might be a little powerful too is to say, listen, if this was my eye, I would rather have this treatment than
Yeah.
taking drops. I think people would really respond to that.
Yeah. There was
I
a study,
noticed
I think,
that-
looking at glaucoma specialists, and by far and away, that was the preferred initial treatment over.
Yeah.
That's
I was gonna mention another new surgery that I've been doing here in the States called Aliflow. Have you guys heard of this, Jeff or Jorge?
yeah.
Have you done
Aliflow.
any?
I have not done
Yeah.
any.
Yeah, so basically what it is, you know, because you know that CyPass was taken off the market. We actually have one CyPass at Hospital Della Familia still there. We should put it in a glass box, you know, as in a museum. But anyway, it's a suprachoroidal MIGS. So what you're doing is creating a cyclodialysis cleft, a very small one. And in order to keep it patent and open, you insert these scleral spacers. So it's human processed sclera. It's been irradiated, made acellular, and they cut it into little thin strips and they put it in this little injector. And so you go in there into the cleft and you push a button and release the injector, and you're able to lay these two, I usually put two, you can put 1, 2, or 3 scleral spacers in that's what keeps the cyclodialysis cleft open. So I've done about 20 of them, and it's a great surgery because number one, it's a MIGS. So it's ab interno. So you don't have any external sutures. It's not a foreign material. It's biocompatible, supposedly less scar tissue inflammation. Takes about 10, maybe 15 minutes, really quick recovery. And and it works, at least in the short term. There's I think 2-year data in the US. And it's, relatively easy to use and learn. So it's a small company called Trek, and I will, been meaning to talk to them about getting some donations and bringing them to Guatemala for my July trip. But I use it in all my failed Zens, people that have failed trabs, tubes that don't want to have a second tube. And, I've gotten some really good results. It really reduces medication burden. I've had a couple failures where the spacers I actually had 2, and I redid them today, where the spacers have come together and the cleft closes. So there is definitely a learning curve, but I'd be willing to bring some down and teach the doctors down there how to do it.
Amazing. Thank you, George. But I wonder if it's just sclera. Does it like fuse with the tissue of the eye, or I mean, how much scarring have you had? I don't know.
Haven't, as long as you put this 2 spacers far enough apart, it will stay in place. And I imagine that it kind of sticks to the choroid, because I've had to go back in and it is sticky, because it's human tissue. But as long as the spacing is enough, I don't think it'll scar so much that it'll completely close off. It's an interesting surgery, and it's not a synthetic material, which is kind of interesting. And it's completely ab interno. And, there are other suprachoroidal devices in trials. There's the iStar device, the little sponge, but they're having a really difficult time recruiting people for the FDA trials. And that's probably at least 2 years away. And there's a Ciliatech is a company in France, and they don't have any plans for FDA approval in the US. So, what happened with CyPass. I think the company's looking at the endothelial counts, and so far so good, at about a year. So it should be interesting.
Amazing. Thanks for sharing. So thank you. See you next week, guys. Thank you, George.
All right. Keep up the good work, team.
Great
Good
to
job.
see you guys.